Hey my people, this is Dr. Shivam, and as your AIIMS PG exams are very near, May AIIMS, so the most important thing you should do is to revise your previous year paper, and that is why my main aim for today's discussion is to discuss and anticipate more future questions for your May AIIMS. So would require your important few minutes with me, and I'm sure you will gain a lot of useful inputs from this presentation. So if we see, the first question that was asked was, which of the following is not seen in superior semicircular canal dehiscence? The options were Tullio phenomena, sensorineural hearing loss, autophony, oral fullness. Now to understand and answer this, you must know the basic concept of superior semicircular canal dehiscence and the sound conduction, the mechanics. This figure here shows you a dehiscence. Dehiscence basically means a defect in the bony semicircular canal. So if you see here, you can see a dehiscence or a defect from where the perilymph is communicating to outside. And what will be the end result of that is, you will be amazed to know when the stapes will vibrate to conduct the sound from middle ear to inner ear, the vibrations from perilymph will go to outside. That means some of the vibration will get wasted, and as a result you will be getting less sound. So basically the thing you need to emphasize here is, we are getting here a conductive hearing loss. Why? Because the conduction mechanism is impaired, and that is why we will get a conductive hearing loss due to an inner ear pathology. So have you ever imagined any inner ear thing that is causing conductive hearing loss? Up till now you were reading about the ossicular necrosis, ossicular disarticulation, tympanic membrane perforation that were causing conducting hearing loss. But here, inner ear disease, those were the middle ear or the tympanic membrane external ear deformity. But here it is the single most, you can say, the inner ear deformity which is causing you a conductive hearing loss. So that is why it is important, and AIIMS people have asked it. So you should know more about it, because to counteract the future questions. So here one thing you know now, that superior semicircular canal dehiscence, which is also known as third window effect. Why we are saying it a third window? Because already you have two windows, one is oval window and another is round window. So the normal mechanism was, the sound conduction vibrates the tympanic membrane, it vibrates the malleus, incus, stapes, and stapes foot plate. Vibration is conducted via the oval window to the perilymph scala tympani, and finally the round window membrane will bulge out and cause the conduction. Though basically the oval window and round window are both in opposite phase. If one goes inside, other goes outside. So phase difference is very important for proper conduction, and this third window effect is causing this phase difference to lose out and the sound conduction to lose out to the outer environment. So this is causing some more effects rather than your conductive hearing loss. Other effects are Tullio phenomena, which is the vertigo when exposed to loud noise. So whenever a person with superior semicircular canal dehiscence or third window effect is exposed to loud sound, he will have vertigo. He will have oscillopsia, that is the objects will vibrate, seems to vibrate to the patient. He will have vertigo when with the pressure changes in the ear, that is called Hennebert's sign. So basically these will also be seen in superior semicircular canal dehiscence. Now if we go again to our MCQ and see our options, which of the following is not seen? Tullio phenomena, yes, patient will have vertigo with the loud noise. Sensorineural hearing loss, no. Conductive hearing loss is seen, and this is a special case of inner ear deformity disease causing the conductive hearing loss. Autophony, yes. Oral fullness, yes. So here the answer becomes sensorineural hearing loss, because repeating again, superior semicircular canal dehiscence causes conductive hearing loss. Now some more points regarding this third window effect or superior semicircular canal dehiscence is, it is basically a congenital thing but may not present early in life. It is male and females are equally affected, and basically symptoms are of vestibular, that is Tullio phenomena, oscillopsia, auditory and vestibular symptoms are less. Another thing is the stapedial reflex is present here. Now the anticipated question is, in case a clinical scenario is given to you where they have said the patient is presenting with intact tympanic membrane but there is a conductive hearing loss. Now here two scenarios come. One is otosclerosis, another is this superior semicircular canal dehiscence. In otosclerosis you will not get stapedial reflex. You will get conductive hearing loss, tympanic membrane will be intact. Here also you will get conductive hearing loss, tympanic membrane will be intact, but in otosclerosis, stapedial reflex is absent. In superior semicircular canal, stapedial reflex is present in addition with some other vestibular symptoms like Tullio phenomena and this oscillopsia and other things. So this is very important for you to know. So this presence of stapedial reflex will differentiate it with the otosclerosis. And how we diagnose this superior semicircular canal dehiscence? So definitely we will be needing one imaging thing. So HRCT, that is high resolution CT scan of temporal bone, is an important imaging modality to diagnose superior semicircular canal dehiscence, and I will show you how it looks like. So this is a CT scan picture, HRCT of temporal bone, where you can see the spiral cochlea. So nowadays they are more clinically oriented. So in our residency we used to see these CT scans. So in that CT scan you will see this spiral as cochlea. So you have read it, now you can see it through your CT scans, and here you can see a bony defect which is the dehiscence of the roof of superior semicircular canal, and this picture can be given you in the question. So you have to identify this dehiscence and answer it according to the superior semicircular canal thing. This is another HRCT where you can again see the dehiscence. So this is just to give you a clinical touch to this topic, because more of clinical things are now being asked. And regarding third window effect, not only superior semicircular canal dehiscence is caused, there are other causes also. Now, as they have touched this third window effect, your next question in May AIIMS can be, what are the different causes of third window effect except? So you should know these causes, and these can be your semicircular canal window in any of the superior, posterior or lateral canal. It can be in the vestibule like large vestibular aqueduct syndrome, inner ear malformation causing dehiscence between internal auditory canal, in cochlea, that is dehiscence between the carotid canal and the scala vestibuli, some inner ear malformations, and anatomical third window. So any third window anywhere else, congenital anomaly can be seen. Now moving to the second question, which is also a very important topic and will be detailing about it, is with regard to the vocal fold palsy. So we will see what they have asked. A patient here has underwent a lateral skull base surgery few months back, presented with complaints of recurrent aspiration. So you have to point out the symptoms patient is presenting to fetch the diagnosis. So recurrent aspiration. Aspiration is one positive finding. There is no change of voice of the patient. So one negative finding is from the history, voice of the patient is normal. Which of the following is of nerve is most likely injured during the surgery? Vagus nerve, glossopharyngeal nerve, superior laryngeal nerve, and recurrent laryngeal nerve. So we will answer this once we go to our basics and know, and then we'll re-come to this question. Now if we see and revisit the nerve of larynx in an easy way, because most of the time students get confused with the nerve supply, I am telling you the easiest way you can remember it. So you have to remember that there are anyway two branches of vagus. One is superior laryngeal nerve, another is recurrent laryngeal nerve. Superior laryngeal nerve has another two branches. One is external and one is internal. Okay, so recurrent laryngeal nerve, superior laryngeal nerve. Superior laryngeal nerve have another two branches, internal and external. Now, this internal branch of superior laryngeal nerve is sensory and the external is motor. Okay, this is sensory and this is motor. Now, the whole of the larynx can be divided into motor supply and the sensory supply. If you see the motor supply, all the intrinsic muscle or most of the muscles of larynx are supplied by, you all know this, recurrent laryngeal nerve, except one muscle, that is cricothyroid, which is the tensor of larynx, is supplied by the motor branch of the superior laryngeal nerve, and motor branch was external laryngeal nerve. Internal laryngeal nerve is an sensory branch which pierces the thyroid membrane and supplies the upper part of the larynx. By upper part, what I mean is the upper part of the larynx above the vocal cords. So above the vocal cords is supplied by the sensory branch of superior laryngeal nerve, and below the vocal cord is supplied by the recurrent laryngeal nerve, the sensory supply. This was the sensory supply above the vocal cords by internal branch of superior laryngeal nerve and below the vocal cords by the recurrent laryngeal nerve. The motor supply, everything is supplied by recurrent laryngeal nerve. You ask me anything, everything, but except cricothyroid, which is supplied by the external branch of superior laryngeal nerve. And what is the function of this cricothyroid? It is basically tensor of vocal cord. It tenses the vocal cord, helps in professional singers to increase and decrease their voice, means increase and decrease their pitch. So in professional singers and voice users, this external branch of superior laryngeal nerve has a vital role, and that is why in most of the thyroidectomies we try to preserve this in case of professional voice singers. Importantly in those, because they have their profession, their occupation with voice. And if you see, the most important nerve is recurrent laryngeal nerve. Why? Because it supplies most of the muscles of the larynx, as well as it supplies the only abductor of vocal cord, that is posterior cricoarytenoid, that is responsible for abducting or opening of vocal cord, without which the patient may have distress due to stridor. Okay, so recurrent laryngeal nerve, you remember everything except cricothyroid, which is supplied by the external branch of superior laryngeal nerve. Now once we know this, we will have to know the different conditions or the different situations of vocal cord palsy. Now, there are two nerves we told, one is superior laryngeal nerve, one is recurrent laryngeal nerve. Now, for both the superior and recurrent laryngeal nerve, either the palsy can be unilateral superior laryngeal nerve palsy or bilateral. In a similar way, in recurrent laryngeal nerve, it can be unilateral or bilateral. And we will discuss in both the scenarios what management we do, what symptoms we get. But before that, I would revisit the question and tell you how we are going to answer it in an easy way. Now moving to here, they said there is complaints of recurrent aspiration. Now as you know, the sensory supply of larynx in upper part is by the superior laryngeal nerve. That means if we lose the sensory supply of the larynx upper part, any food that the patient is taking, he will not have sensation, and that food may go into the inlet of larynx causing aspiration. So this point of recurrent aspiration gives us a hint of loss of sensation on the upper part of the larynx where the food is going, and that is why it is causing aspiration. Second point is no change in voice of the patient. Now, if the patient is having recurrent laryngeal nerve palsy, in all and every case he will have a hoarseness, that means change of voice. But in case of superior laryngeal nerve palsy unilateral, the patient may not present with hoarseness of voice. Why? Because it is only involved with the professional or singers who used to modulate their voice. But in normal person, this unilateral superior laryngeal nerve palsy may not present as hoarseness or change of the voice. So for this question, the answer is superior laryngeal nerve palsy, because here there was no change of voice and there is aspiration. Now we will see what all conditions can be possible, different questions which can be possible from vocal cord palsy and some more related questions. So be with me for some more minutes, because these are, although difficult, but are very important and will be asked in your AIIMS or Neetpg or PGI. I don't know in which exam, or maybe in all the exams. So first we will discuss the first situation, that is for this question, that is unilateral superior laryngeal nerve palsy. In this case, what will be affected? It is supplying the one muscle, that is cricothyroid, which is tensor. So here pitch of the voice cannot be changed, and there will be unilateral anesthesia of larynx above the level of vocal cord. Usually does not require any treatment. That means with conservative treatment things resolve. But now if it is bilateral, then the voice will become breathy and weak, and there will be high chances of aspiration, because both the side there is no sensation. Then what you need to do is, to prevent aspiration, you can do a tracheostomy or epiglottoplexy to close the laryngeal inlet and protect the lungs from recurrent aspiration. That means here main motive of bilateral palsy of superior laryngeal nerve is not respiratory distress, but of preventing the aspiration, because both the side of laryngeal inlet have lost their sensation. You got my point? Now moving to the recurrent laryngeal nerve palsy. Very important nerve. Most of the general surgeons fear this nerve. Why? Because they find it difficult to identify. And I would tell you that is why now most of the thyroid surgeries have moved to the ENT and head neck surgery domain, because we are more used to see this nerve, search this nerve, see its root and preserve it. So preserving this nerve is very important, and you will get to know why it is important. Now in case of unilateral and in case of bilateral. In case of unilateral palsy, that means the only abductor got paralyzed. Posterior cricoarytenoid is now paralyzed. This will lead to paralysis of all the muscle except cricothyroid and including posterior cricoarytenoid. Now one side vocal cord cannot be abducted, so the vocal cord will be in paramedian position, and there will be slight hoarseness which may improve over the days due to compensatory movement of the other side of vocal cord. So that means if this is not moving, so compensatory moving of the opposite side vocal cord will change or will compensate for the loss of the movement of other side of vocal cord. So only speech therapy will help with unilateral recurrent laryngeal nerve palsy. But most dreaded is bilateral recurrent laryngeal nerve palsy. So in total thyroidectomy, you always try to preserve both, and if not both, in case of cancer or any other thing, you try to preserve one side of a recurrent laryngeal nerve if it is not involved by the cancer, because bilaterally damaging of recurrent laryngeal nerve will cause stridor. So patient will have severe respiratory distress, because both the vocal cord now are not moving and they are either in median or paramedian position. Patient cannot inhale. Patient is having stridor. So the emergency procedure that is required to save the patient life in these cases is tracheostomy. Now you will do a tracheostomy to save life, to save the patient from respiratory distress or stridor. So here the voice will be good, but patient will be having stridor. Why voice will be good? Because vocal cords are anyway in opposed to each other. So cannot open, but they are opposed to each other. Voice, whatever air will come, it will vibrate the vocal cord, but it cannot open. So laryngeal inlet cannot open. Patient cannot breathe. Air cannot go inside because of closed vocal cords. So here we will do an emergency tracheostomy as an emergency procedure. Now there are some other procedures which preserves voice and saves the patient, like we call it widening the respiratory airway without a permanent tracheostomy, and aims are to preserve the voice. So this can be done by arytenoidectomy, with suture called Woodman's procedure. Woodman's procedure is basically an external approach where we remove one part of arytenoid and suture the vocal cord to open the airway. So basically this is external approach and now these have replaced the with less invasive techniques like Kashima's operation. So do Google Kashima operation, you will get a lot of things. So these are basically transverse cordotomy where we remove a part of vocal cord with the help of lasers to allow the airway in case of bilateral recurrent laryngeal nerve palsy. We also do now reinnervation procedures at some centers and type 2 thyroplasty. Now this is type 1, 2, 3, 4. There are 4 thyroplasty that I will discuss because it can be an anticipated question. Here we do type 2 thyroplasty, that means lateralization of the vocal cords, because vocal cords are adducted, so we have to lateralize the vocal cord. That is called type 2 thyroplasty. Ishika's classification. There is one classification called Ishika's classification that has 1, 2, 3, 4, 4 types of thyroplasty, and type 2 is lateralization thyroplasty, which is being done for bilateral recurrent laryngeal nerve palsy. So another future question, in case of bilateral recurrent laryngeal nerve palsy, which of the following thyroplasty will have to be done? So it is type 2 thyroplasty. Now, for vocal cord palsy, there can be different causes. One is central, another is peripheral. Most of the causes are peripheral. That you can see 90% of the causes are peripheral. Now, the most common cause of vocal cord palsy, if you see, is idiopathic. Okay, and is the most common cause of paralysis of vocal cord, I'll change it to the most common cause is iatrogenic, basically caused by the surgeon. So surgical trauma is the most common cause of vocal cord palsy. Other causes can be malignancy. Most among the malignancy is the bronchial carcinoma. Other causes are viral factor, bacterial infections, glomus tumor, and all these. So paralysis can be central and peripheral. Among peripheral, it can be high vagal palsy or low vagal palsy. High vagal palsy is due to lesion which is proximal to nodose ganglion. Now, what do I mean by this proximal to nodose ganglion? Here, all the nerves supplying half of the larynx will be involved, causing combined paralysis of half. And what will be caused by the low vagal palsy? In low vagal palsy, the recurrent laryngeal nerve will be damaged, but the superior laryngeal nerve will be preserved, and that is why cricothyroid will be preserved in low vagal palsy. Low vagal palsy, because superior laryngeal nerve has already taken branch from the vagus, so it is preserved. So cricothyroid is intact while recurrent laryngeal nerve is damaged. Now what is more common? So low vagal palsy is more common than high vagal palsy, and it occurs more on the left side than right side because of its longer course. Now here two MCQ arises. One is, as such, the left recurrent laryngeal nerve is more prone to get palsy because of its longer course. Now if in MCQ they ask you which of the following nerve will get more commonly injured or palsy by the neck surgery. So if they say during thyroidectomy, which of the following nerve are more prone to get injured, then right recurrent laryngeal nerve is more prone to damage due to its position, due to its more superior position, so more superficial position. So as such, overall, left recurrent laryngeal nerve is more prone to damage or get palsy or get injured, but in neck surgeries, the right recurrent laryngeal nerve will be more injured, more prone to injured. Also, in left recurrent laryngeal nerve palsy, the causes of thorax like bronchogenic carcinoma, mitral stenosis, there is one syndrome, Oatner syndrome. So I would like you to tell me in my comment section, maybe by googling, but you should know what is Oatner syndrome, and I will reply you in that comment by an appreciating effort, or means basically will appreciate your effort of commenting on my desk. So do write me what is Oatner syndrome. Now, which of the following is most common cause of vocal cord palsy? You all know it is surgical. So this was one anticipated question and already asked in May 2014. Okay. Yeah. So carcinoma bronchus as such is most common cause for left recurrent laryngeal nerve palsy, while thyroid surgery affects right recurrent laryngeal nerve. So increased chances during thyroidectomy. So you already know this point. So we were talking about the anticipated questions regarding Ishikawa's thyroplasty. So type 1 is medialization of the cord, type 2 is lateralization of the cord, type 3 is shortening of vocal cord. Now if you do a procedure which shortens the length of the vocal cord, it will lower the pitch. Okay, so why it is important? Because in case of puberphonia, like males having female voice, means high pitch voice, if you make the vocal cord lax, it will lower the pitch, and lowering the pitch means male character voice. So in case of puberphonia we do type 3 thyroplasty. In case of androphonia, where we need to correct the low pitch to female voice, that is high pitch, we lengthen the cord, we stretch the cord so that pitch gets increased. So in case of puberphonia type 3, in case of androphonia type 4, in case of puberphonia type 3, in case of androphonia type 4. So another MCQ. Now this was the third question which was asked in November AIIMS 2019. A young man with a history of ear infection presents with a smooth erythematous swelling on the mastoid process. So basically a child or young man with a history of ear infection presents with smooth erythematous swelling on the mastoid process as shown. What is your likely diagnosis? So basically, first, we will go through the option: furunculosis, acute mastoiditis, fibrous dysplasia, facial paralysis. Now, what you all think, what it can be? If we go with the clinical scenario they have given, they say it is smooth erythematous swelling. So basically, you all know a condition called ironed out mastoid. So what do you mean by this? Basically, there will be a smooth bulging out of the posterior auricular region, and here you will get a ear infection history. So they were saying ear infection history, but the appearance, the clinical picture is acute mastoiditis. And why not furunculosis? For furunculosis, we need some more points to get to the diagnosis. For furunculosis, they should have mentioned ear pain, which is not mentioned anywhere in this question. So in furunculosis, the patient will be complaining of ear pain while introducing anything, or as such patient will be having ear pain, some discharges. So the scenario which is given here points more towards acute mastoiditis, that is the ironed out appearance of the mastoid, which is the result of acute mastoiditis and not furunculosis. So do see the differences between the furunculosis and acute mastoiditis, and in coming more videos I will discuss in more detail these things. So I hope this small session have helped you to clear the concept. Do tell me in the comments how these things are helping you and what all you need in future. So this is Dr. Shivam, hoping and wishing you all the healthy things. And basically the time is crucial. We are going through a tough time, but be strong, things will improve. And be happy, stay happy, stay healthy, and we'll see you in the next video. Okay, thank you. Signing off.